failure to thrive, or malnutrition. Our contents are definition of the disease, causes and risk factors, assessment findings, signs and symptoms, diagnostic tests, medical and surgical management if applicable, nursing interventions include pre-op and post-op management if applicable, family education and health maintenance. The definition of failure to thrive or malnutrition is the inadequate physical development of an infant or child manifested as a deceleration in weight gain, a low weight height ratio, or a low weight height head circumference ratio. Next is causes and risk factors. Weight loss in early stages. If poor intake continues, linear growth slows down or ceases. In latent stage, head circumference growth is retarded, indicating compromised brain development. Risk factors include short stature, behavior problems, developmental delay. Associated disorders include asthma, cardiac failure, thyroiditis, congenital heart disease, neurologic lesions, hydrophorosis, adrenal hyperplasia, diabetes insipidus, cystic fibrosis, chronic or recurrent urinary tract infection or UTI, hyperthyroidism, autoimmune disorder, and immunodeficiency. Assessment findings, signs and symptoms. Organic FTT. First, retarded growth accompanied by manifestation of the underlying disease. Second, weight loss in early stages. If poor intake continues, linear growth slows down or ceases. In latent stage, head circumference growth is retarded, indicating compromised brain development. Third, developmental delays. Fourth, infant stress, irritability, fussiness, jitteriness. Fifth, feeding disorders, ineffective sucking, difficulty chewing, difficulty swallowing. And last, clinical symptoms can include vomiting, hyperthermia, lethargy, muscle wasting, decreased subcutaneous tissue, hypoalbuminemia, eczema, hair loss, and diarrhea. Next is non-organic FTT. First, retarded growth. Second, infant stress, irritability, fussiness, and jitteriness. Third, feeding disorders, ineffective sucking, difficulty chewing, and difficulty swallowing. Fourth, reduced energy level. Fifth, difficulty temperament. And sixth, fitful sleep. Seventh, reduced responsiveness and interaction with the environment. Eighth, social isolation, lack of vocalization. Ninth, spasticity or rigidity when touched. 10th, inability to make an eye contact or smile. 11th, refusal to eat, rejection of foods. And last, spits up, gulch, cough with feeding, rumination. And next is diagnostic tests. First, failure to thrive suggested if a child is falling off a previously established growth curve or falls below the 5th percentile. If FTT is of recent onset, weight but not height will fall below accepted standards. Depression of weight and height indicates chronic malnutrition. Second, techniques of evaluating growth. Look at growth percentage of the median for that age. Divided the actual value of height or weight by median value for that age. Third, complete health and dietary history. Feeding, eating pattern, 3 days calorie count. And fourth, physical examination for evidence of organic causes with particular attention to ears, facial structures, mouth, heart, lungs, abdomen, and neurologic system. Fifth, assessment of prenatal, perinatal, and postnatal infections. 6. Developmental assessment. And last, family assessment, family short stature syndrome, and family dynamics. These are the tests to rule out organic conditions. First, complete blood count or CBC with differential and indices sedimentation rate to rule out anemia or hematologic or inflammatory cause. Second, blood cultures if fever is present. Third, urinalysis and urine culture as baseline for bladder and renal function. Fourth, thyroid, stimulating hormone, and free thyroxine to rule out hyperthyroidism. Fifth, blood chemistry. Provide data on electrolyte balance, renal function, and skeletal disorders. 6. Neonate screening tests or torch studies. 7. Stool screening tests to be ordered if diarrhea or abnormal stools are present. 8. Radiologic studies including upper GI series, barium swallow, reflux workup, upper endoscopy, and sweat tests.
Medical management. Immediate treatment is directed at reversing malnutrition. All children with FTT or failure to thrive need additional calories for catch-up growth, typically 150% of the caloric requirement for their expected, not actual, weight. Nutritional treatment is aimed at providing sufficient calories to support catch-up growth, to restore deficits in weight and height. Medical management. Multivitamin supplementation containing zinc and iron is usually recommended. Fat-soluble vitamins A, D, E, and K if fat malabsorption is present. If cause is organic, the underlying disease entity is treated or managed. In non-organic FTT or failure to thrive, hospitalization is avoided unless the child is in imminent danger because it further disrupts the patient-child relationship. Therefore, frequent home or clinic visits are necessary. Referral to feeding disorder clinic or rehabilitation center may be necessary. Developmental interventions through occupational and physical therapy are instituted if necessary to prevent further delay. Support, education, and financial assistance are offered to the family. Nutrition, occupational therapy, and physical therapy consults are indicated. Nursing interventions include pre-op and post-op management if applicable. Nursing interventions. A. Promoting adequate nutrition. Promoting adequate nutrition. Number 1. Facilitate nutritional consultation. Number 2. If hospitalized, provide a primary core of staff to feed the child. Number 3. Develop individualized teaching plan to instruct parents of child's dietary needs. Specify type of diet, essential nutrients, serving sizes, and method of preparation. Number 4, provide a quiet, non-stimulating environment for eating. Number 5, demonstrate proper feeding techniques including details on how to hold and how long to feed the child. Number 6, administer multivitamin supplements as prescribed. Number 7, encourage nutritious, high-calorie, and fortified fluids to increase nutrient density. For infants, use 24 to 30 calorie per ounce rather than 20 calorie per ounce. For older children, suggest fruit smoothies using whole milk and ice cream. Number 8, refeed the malnourished child with caution. Monitoring electrolytes, calcium, magnesium, and phosphorus daily or more frequently if abnormal. Gradually increase nutrients and use small, frequent feedings with adequate fluids to ensure hydration. Monitor intake and output. Number 9, maintain high nutrient diet until weight is appropriate for height, usually age 4 to 9 months. Number 10, advise family that some nutritional intervention will be continued until appropriate height for age is reached. B. Promoting adequate growth and development. 1. Obtain accurate weight at every visit or every day if hospitalized. 2. Assess child's growth by using age and gender-appropriate growth charts. Extremely low birth weight infants born with major abnormalities have nearly twice the risk of neurodevelopmental impairment, and 3639 ABCD increased risk of poor growth. 3. Assess child's development by interviewing the parent or caregiver or using developmental screening tests such as the Denver second or 2. Denver Developmental Materials Incorporated. 4. Observed interactions between parents and child and among family members, including eye contact, communication patterns, and coping ability. Number 5. Provide the infant with visual and auditory stimulation by exposing to bright colors, shapes, and music. Provide the older child with age-appropriate stimulation, such as books, games, and toys. Place the infant prone while awake on the floor to encourage trunk control. Number 6. Encourage periods of scheduled rest and sleep. C. Promoting effective parenting. Number 1. Teach the parents, especially the mother, normal parenting skills by demonstrating proper holding, stroking, feeding, and communication using age-appropriate words and gestures. Number 2. If hospitalized, encourage and facilitate the parents to spend as much time as possible with the child. Number 3. Educate the parents to recognize and respond to the child's distress and hunger calls. Number 4. Help the parents to develop organizational skills. Write down daily schedule with meal times, time for shopping, and so forth. Number 5. Refer for counseling, if necessary, to help parents overcome feelings or mistrust or neglect resulting from adverse personal childhood experiences. Number 6. Refer to social services to help resolve any social and financial difficulties that might interfere with providing a nurturing environment. Number 7. Monitor parents' progress and provide positive reinforcement. Family education and health maintenance. Number 1. Reinforce the need for a quiet, non-threatening, nurturing environment. Number 2. Encourage the parents to be consistent with feedings. Although forced feeding is avoided, strict adherence to appropriate feeding is essential for growth. Number 3. Advise the parents to introduce new foods slowly and follow the child's rhythm of feeding. Number 4. Review the importance of providing a routine rest schedule in an environment that is conducive to sleep. Number 5. Review development, stressing need for visual, auditory, and tactile stimulation and age-appropriate toys for continued development. Number 6. Reinforce the need for follow-up care, well child visits, and immunizations.